I want to talk about one way you can diagnose autoimmune diseases and then how you treat them. Not any particular autoimmune disease, but just kind of in general. So some of the common autoimmune diseases are rheumatoid arthritis and systemic lupus erythematosus. You can just go on and on. So first you can do what's called a synovial fluid analysis, where you stick a needle into the swollen and inflamed joint, aspirate some of the synovial fluid out, and look at it and analyze it. And if it has crystals in it, it might be gout or pseudogout. If it has blood, maybe it's just a traumatic injury and you have some hemarthrosis in there. Is it infectious? Do you have a staph infection? Staphylococcus aureus can get, into a joint maybe after surgery or something. I've had patients that happened to, and it just is completely devastating and makes up for a hard recovery. Is there white blood cells? So this one's really important because you can quantify the amount of white blood cells. There's a few cutoffs. So at 2,000, if it's less than 2,000, it may just be general osteoarthritis, old age and wearing away of cartilage. If it's greater than 2,000, it's probably some kind of inflammatory autoimmune disease like rheumatoid arthritis that's causing the inflammation in the joint. And if it's greater than 100,000, then it's septic, and it's probably something like a staph infection. So once you've determined that, maybe your white blood cells are greater than 2,000 and we have autoimmune disease, what's some treatment options medically? So I kind of have different classifications of drugs that work similarly here together. So one classification, these drugs both inhibit the division of inflammatory cells. So inflammatory cells rapidly divide. So if you can hit the rapidly dividing cells, it's going to suppress the immune system. And that's what we want to do with all these drugs, is suppress the immune system. It's hyperactive. It's too much. So we want to bring it down. And inevitably, a side effect of all this is going to be that you are more susceptible to infections because you've knocked down this protection from our white blood cells. So methotrexate works by inhibiting two enzymes. And so these enzymes are important in the making of nucleotides. So remember, nucleotides are the building blocks of nucleic acids. And we have to replicate our DNA each time you make a new cell. If for some reason you have some enzymes that are inhibited that are in that pathway of making the nucleotides, then you're not going to get the nucleotides, you're not going to get the DNA, and you're not going to get division of the cell because you haven't been able to replicate your DNA. So just to kind of give you the enzyme names, there's folate is really important for making DNA, and dihydrofolate has to get to tetrahydrofolate via an enzyme called dihydrofolate reductase. So methotrexate will inhibit that, and that's a key step in getting to a nucleotide ultimately. And then further down the pathway, there's another enzyme called thymidylate synthase. So whenever you have DUMP, and that stands for deoxyuridine monophosphate, what it does is it has to get over to deoxythymidine monophosphate. If you remember, thymines are some of the key components of our DNA. We have A's, T's, C's, and G's. Without T's, we can't make DNA. And so if we don't have that key conversion, because methotrexate is inhibiting thymidylate synthase, then we can't get to that key step. So two places where methotrexate kind of shuts down the division of rapidly dividing cells. So it's also an anti-cancer drug for that reason. Cyclophosphamide, which also does this and is also an anti-cancer drug, it's considered a nitrogen mustard drug, an alkylating agent, and it's going to prevent this division as well. What about cytokines? Cytokines are inflammatory, and you have different cytokines, different interleukins and tumor necrosis factor. What cyclosporin does is it prevents the secretion of cytokines, specifically interleukin 2. So what it does is this drug will go in and go all the way to the DNA level and decrease expression of interleukin 2. Interleukin 2's main job is to go and increase proliferation of T helper cells. So these are T lymphocytes that are basically that sound off the alarm for just inflammation to take place, these helper T cells. So if you don't get that proliferation because you don't have this cytokine available to tell white blood cells to make these T helper cells, then that's going to really attenuate the inflammatory process. So that's important. And cyclosporin is used a lot for tissue rejection as well, or transplant, rejection after a transplant. All right, another one that works at the DNA level is corticosteroids, more specifically glucocorticoids. So these are like your prednisone, methylprednisone, dexamethasone, hydrocortisone, lots of different glucocorticoids. And what they do is they go into the DNA level and they'll change expression of two important proteins. One protein they downregulate is called cyclooxygenase 2. So these COX enzymes are used to make prostaglandins, and prostaglandins increase inflammation. And then there's another one that it upregulates called lipocortin. And what lipocortin does is it goes further higher than the COX enzyme, further in this pathway of making a prostaglandin at the beginning. So at the beginning, the first thing that happens is there's an enzyme called phospholipase A2. And what it does is it's a phospholipase. It's going to cut a 20 carbon segment off a phospholipid, and that is your precursor to make prostaglandins, the first step. It's called arachidonic acid. And so what lipocortin does is it goes and it binds to that phospholipase A2 and inhibits it from making that cut, and you never get any further than that as far as getting to prostaglandins. And then it has another, it's downregulating the COX enzyme, so it's really helping with limiting inflammatory prostaglandins. And then this one down here, this is T for T cells. So when T cells release certain cytokines, one pro-inflammatory cytokine that really gets the inflammatory pathway going is tumor necrosis factor alpha. And so once it's out there, it's gonna cause inflammation. But what if you have a monoclonal antibody like infliximab that goes and forms a complex with this tumor necrosis factor alpha, this TNF alpha that's out there, and negates it from having any effect on what it does downstream as far as inflammation? Then we have another one that works similarly called etanercept or Enbrel. And what it does is it's a receptor that binds to tumor necrosis factor alpha, and then it doesn't have its inflammatory effect. So hopefully that gives you a good idea of just some of the general drugs used to treat autoimmune diseases.